My name is Kalita Prema and I will be presenting the cardiovascular physiology. So starting with the cardiovascular system, which circulates the blood in a closed loop, oxygenated blood from the lungs enters the left atrium, flowing to the left ventricle and is pumped through the aorta to the body tissues. Then the deoxygenated blood returns via the veins to the right atrium, passing through the right ventricle, and it is sent to the lungs through the pulmonary artery for oxygenation before the cycle repeats itself. Now the vasculature. The arteries are thick-walled and under high pressure they carry oxygenated blood, while the arterioles are the site of high resistance, which regulate the blood flow via autonomic control. The capillaries are thin-walled and large surface areas which facilitate the exchange of nutrients and gases, and veins, which hold the largest blood volume under low pressure, return the blood to the heart and contain alpha-1 adrenergic receptors. The viscosity. Now the blood velocity is determined by the equation V is equal to Q by A, which the velocity is directly proportional to flow and inversely proportional to the cross-sectional area. The velocity is higher in vessels with small cross-sectional areas like the aorta and lower in capillaries where slower flow optimizes nutrient and gases exchange. Now the blood flow is driven by a pressure gradient and which is inversely related to the vasculature resistance, the ohms, similar to the Ohm's law for electricity. Now this resistance is influenced by the vessel's length, blood viscosity and vessel radius, with the radius having the most significant effect. Decreasing radius greatly increases its resistance. Now in parallel circuits like the systemic circulation, total resistance decreases as more vessels are added in series and resistance sums up along the vascular path. So the blood flow can be laminar or turbulent, with turbulence increasing at higher velocities and lower viscosities as predicted by Reynolds number. The mean arterial pressure is basically the average arterial pressure over the time and is thoroughly calculated as the diastolic pressure plus 1/3 of pulse pressure. Their venous pressure is low due to the veins having high capacitance, allowing them to hold the large blood vessels volumes at low pressure, as the arterial pressure is slightly lower than the venous blood pressure, while the left arterial pressure estimating using the pulmonary wedge pressure measurements. Now the cardiac electrophysiology focuses on electrical activity of the heart recorded as an ECG, which consists of the P wave representing the arterial repolarization, the PR interval measuring the conduction from the atria to the ventricles, the QRS complex showing the ventricular depolarization, the QT interval which represents the total period of ventricular depolarization and repolarization, and the T wave which indicates the ventricular repolarization. Now the cardiac action potentials basically differ between regions like ventricles, atria, Purkinje fibers and the sinoatrial node. In the ventricles, the action potentials occur in 5 phases, which is the 0 to 4, which involving the ion movements like sodium, potassium and calcium. The sinoatrial node is basically the heart's pacemaker, which is exhibiting automaticity with spontaneous depolarization during the phase 4, setting the heart's rhythm. This is driven basically by inward movement of the sodium and calcium currents, and other areas like the AV node can also pace the heart but at slower rates. The conduction velocity refers to how fast the electrical signals spread through the heart. It depends on the size of the inward current during the action potential, the fastest conduction of the Purkinje fibers, while the slowest is the AV node, which allows time for the ventricles to fill with blood before contraction. Now, excitability basically is the ability of the heart cells to initiate an action potential in response to a stimulus, and it varies during different phases of the action potential and is also defined by refractory periods like absolute refractory period where no action potential can be initiated, effective refractory period, a conduction action potential cannot be triggered here, and relative refractory period where an action potential can be triggered but requires more inward current. The autonomic effects on the heart rate and conduction velocity. Basically, the chronotropic effects refers to the changes in the heart rate. Parasympathetic system working on it decreases the heart rate, while the sympathetic system increases it. The domotropic effects refers to the changes in conduction velocity, primarily at the AV node. Parasympathetic stimulation decreases conduction, increasing the PR interval, while sympathetic stimulation increases conduction, decreasing the PR interval. The cardiac muscle and output summary. The myocardial cell structure basically is a contractile unit in the sarcomere. which shortens by sliding filaments actin and myosin, and intercalated disc and jump junctions basically facilitate the cohesion and rapid electrical signal spread. Mitochondria are abundant, and tubules are also help propagate the action potential deep into the cell. The sarcoplasmic reticulum stores and releases the calcium or contraction. Then excitation and contraction coupling. The action potentials here trigger the calcium influx to the L-type channels, which induces further calcium release from the sarcoplasmic reticulum. This is increasing the intracellular calcium, which binds to troponin, enabling the actin-myosin interaction and contraction. Relaxation occurs when calcium is reabsorbed by the sarcoplasmic reticulum. The contractility of the heart. This is the heart's ability to contract forcefully at a given muscle length, which is related to intracellular calcium levels. An increased heart rate, sympathetic stimulation, and cardiac glycosides enhance this contractility. Conversely, if parasympathetic stimulation decreases the contractility of the heart. The length-tension relationship, the preload, which is the end diastolic volume, affects the contraction force via the Frank-Starling mechanism. This higher preload increases the stroke volume and cardiac output. Now, afterload, which is the pressure against which the heart pumps, affects the velocity of the contraction and is inversely related to the contraction efficiency. The ventricular pressure volume loops and the cardiac function curves. Basically, the ventricular pressure loops, volume pressure loops, is basically these loops combine systolic and diastolic pressure curves to show the heart's contraction and relaxation phases. The isovolumetric contraction, which is the ventricle contracting without the volume change after filling, causing the pressure to rise until the aortic valve opens and the ventricular ejection happens. The blood is ejected into the aorta, decreasing the ventricular volume and showing stroke volume. The isovolumetric relaxation is basically when the ventricle relaxes and there is no volume change until the aorta valve opens or closes, and then the ventricle filling. The mitral valve opens and the ventricle refills its end diastolic volume. Now, the factors which are affecting the pressure volume loop is basically increased preload, where there is a raise in the end diastolic volume, increasing stroke volume and loop width. There is also increased afterload, which raises the aortic pressure, decreasing stroke volume and loop width, and increased contractility, which enhances the tension and stroke volume, reduces end diastolic volume, and increases the loop width. The cardiac and vascular function curves basically shows how cardiac output depends on end diastolic volume, which is the Frank-Starling relationship. A vascular function curve is basically showing the venous return as a function of right arterial pressure, and the mean systemic pressure indicates pressure where there is no flow shifting with blood volume changes. Now, venous return curve basically depicts the changes with total peripheral resistance affecting how blood returns to the heart. The equilibrium point is basically the intersection of the cardiac output and venous return curves, representing the steady state where the output equals return. The effects of agents and conditions. Basically, inotropic agents are positive agents which are increasing the cardiac output by enhancing the contractility, shifting the cardiac output curve upside, and the blood volume changes which increase or decrease venous return and mean systemic pressure, shifting the vascular function curve. The TPR changes basically are affecting both the curves simultaneously, which increases its decreasing output and return, and decreasing TPR having the opposite effect of it. Now, the summary of it. Basically, stroke volume is the amount of blood which is affected from the ventricle per beat. The equation is basically the stroke volume equal to the end diastolic volume minus the end systolic volume. The cardio output is the volume of blood which the heart pumps per minute. Equation is stroke volume into heart rate, and the ejection fraction basically is the percentage of end diastolic volume ejected per beat, reflecting heart contractility. The equation is ejection fraction is equal to the stroke volume divided by the end diastolic volume, and the normal value is approximately 55%. The stroke work is basically defined by the work done by the heart per beat, and its equation is aortic pressure into the stroke volume, and the energy source is primarily the fatty acids. And cardiac oxygen consumption is basically related to the amount of tension that the heart develops, which is increasing with higher afterload, and larger heart size is basically greater contractility there will be and higher heart rate. And lastly, the Frick principle for measuring the cardiac output defines as the cardiac output is equal to oxygen consumption divided by pulmonary artery oxygen and pulmonary vein oxygen. Example, if there is a calculation for a man of 250 ml divided per minute oxygen consumption 0.20 oxygen ml in the pulmonary vein and 0.15, then the cardiac output will be 250 ml divided by 0.20 minus 0.15, which is the oxygen consumption in pulmonary artery and pulmonary vein, and the equal to it is 5.0 liter per minute. So basically that's the cardiac output, and the stroke volume will be cardiac output divided by the heart rate, which is 5000 by 72, which is approximately 69.4 ml per beat. Now the summary of the cardiac cycle. When there is atrial systole, it is basically the electrical pacemaker P wave where there is electric atrial activation. The function is that it contributes to the ventricular filling, creating a fourth heart sound S4, which is not audible in healthy adults. The isovolumetric ventricular contraction is basically the electrical pacemaker QRS complex, the ventricular activation, and the function is AV valve closes S1 heart sound, and there is no blood ejected and ventricular pressure rises. Then third, the rapid ventricular ejection, where the pacemaker end of the T wave ventricular repolarization happens, and the function is ventricular pressure exceeds aortic pressure. Aortic valve opens and blood is rapidly ejected and ventricular volume decreases. The fourth one is the reduced ventricular ejection, where the function is ejection shows ventricular pressure decreases, aortic pressure drops, and atrial filling continues. Then there is isovolumetric ventricular relaxation at the end of T wave, and the function is aortic and pulmonary valve opens, S2 heart sound is created, and ventricular pressure decreases, all the valves are closed, and volume is constant, causing the dicrotic notch occurs. Then there is ventricular filling, where rapid ventricular filling, where the mitral valve opens, rapid filling happens of the ventricles from the atrium. The third heart sound S3 can be heard in children or those with heart disease. And lastly, the reduced ventricular filling or diastasis occurs, where the function of slow filling of the ventricle, which is the longest phase of the cardiac cycle, duration depends on the heart rate. The arterial pressure regulation. Number 1, the baroreceptor reflex, where the mechanism is fast and neural regulation. The function is to regulate minute-to-minute arterial pressure. The process is decreased arterial pressure reduces the carotid sinus stretch, which is decreasing the baroreceptor firing, and the vasomotor center responds by increasing the sympathetic activity, which is the heart rate, contractility, and vasoconstriction, and decreasing the parasympathetic activity to raise the blood pressure. Number 2, the renin-angiotensin-aldosterone system, which is also known as RAS. The mechanism is to slow hormonal regulation for long-term pressure control. The process by which it does is that decreasing renal perfusion triggers the renin release, converting angiotensin to angiotensin 1, angiotensinogen to angiotensin 1, and angiotensin 1 is then converted to angiotensin 2 by ACE. Then the effect of angiotensin 2 is basically it stimulates aldosterone release, increasing sodium and fluid retention, which is directly decreasing or increasing the sodium resorption, and stimulates thirst, which is causing vasoconstriction to raise the blood pressure. Then other regulation mechanisms are cerebral ischemia, which is increased brain carbon dioxide, which is triggering the sympathetic outflow, raising the blood pressure to maintain blood perfusion, which is basically the Cushing's reaction, and chemoreceptors, which are located in the carotid and aortic bodies, detect the low oxygen, leading to increased TPR and also arterial pressure. Then vasopressins or ADH can also be released in response to blood loss, increased TPR and water resorption to raise the blood pressure, and atrial natriuretic peptide, which is released from the atria in response to high blood pressure, promotes vasodilation, increases sodium and water excretion, and it basically inhibits the renin secretion and lowering the blood pressure. Then we have microcirculation and lymph nodes. The capillary structure number 1, which are the capillary beds, are net arterioles, which is leading into capillaries, which have no smooth muscles and consist of single layer of endothelial cells. The regulation is of blood flow, which is regulated by the precapillary sphincters and arterioles. Basically, the function is to regulate the blood flow. Then we have substance passages like the lipid-soluble substances like cross capillary membranes, we have the simple diffusion like oxygen, carbon dioxide. Then we have small water-soluble substances which pass through the clefts between the endothelial cells, and large substances use ionocytosis to cross. Then we have fluid exchange, which is basically the Starling equation, which is given by JV is equal to Kf in bracket Pc minus Pi, which is minus pi C, then pi I, and bracket closed. All of this basically stands for the fluid movement is equal to the filtration coefficient multiplied by the capillary hydrostatic pressure minus the interstitial hydrostatic pressure, bracket close, minus capillary oncotic pressure minus the interstitial oncotic pressure, and the net pressure basically determines whether the fluid will move into or out of the capillary. Then we have the lymph function. The purpose is to return the excess filtered fluid and proteins into the capillaries from the capillaries back into the circulation, and this flow is unidirectional, aided by the valves and muscular structures or muscle contractions basically. And the edema basically is a result from excess fluid which is filtrated or blocked lymphatics or due to blocked lymphatics. Then we have endothelium derived relaxing factor, which is EDRA. The function is produced by the endothelial cells, which is relaxing the muscular smooth muscles, and the mechanism by which it does is that activates guanylate cyclase to produce the cyclic GMP, and then nitric oxide is a key of EDRA. There are special circulations like the local intrinsic control, where there is autoregulation, maintaining a constant blood flow despite changes in perfusion pressure like the heart, brain, kidneys. Then we have active hyperemia, which is blood flow increasing with increased metabolic activity like exercise. Then reactive hyperemia, where the blood flow increases after a period of occlusion. Then we have myogenic hypothesis, where the vascular smooth muscles contract when stretched to maintain flow. Then we have metabolic hypothesis, where there is increased tissue metabolism, where it produces the vasodilator metabolites like carbon dioxide, potassium, and enhancing the blood flow. Then we have hormonal or extrinsic control, where the sympathetic innervation like increases the sympathetic tone causing vasoconstriction and decreasing tone causes vasodilation. The other hormones like are also in play like histamine causing arterial dilation and venous constriction leading to local edema. Bradykinin, similar effects to histamine. Serotonin, which causes vasoconstriction and aids in reducing blood loss. And prostaglandins, lastly, which some cause vasodilation like prostacyclin, and others cause vasoconstriction like example thromboxane A2. Lastly, there are specific circulations like coronary circulation, which is regulated by local metabolic factors, example hypoxia, adenosine, which exhibits autoregulation, active and reactive hyperemia, sympathetic nerves, which have a minor role. Then we have cerebral circulations controlled by the local metabolic factors, primarily carbon dioxide, exhibits autoregulation as well, which is active and reactive hyperemia, and sympathetic nerves have a minor role in it. Then we have skeletal muscle, which is regulated by the sympathetic innervation at rest and local metabolic factors during exercise, exhibiting an autoregulation, active and reactive hyperemia, as well as lastly the skin, which is controlled mainly by the sympathetic innervation for the temperature regulation, and local trauma triggers histamine release, causing the triple response of redness, flare, and swelling. Thank you so much. That is all from my side. Thank you so much for listening to the lecture.